Hello friends, welcome back again. So we are heading on to part 2 of controlled ovarian hyperstimulation guidelines by Eshre 2025. So this is the second part of the guideline. We have already discussed the first part of the guideline. So let's start. This is what the guideline is and it's openly available on Google. You can search for it. So in this part of the guideline, we will be discussing the type of gonadotropins and other ovarian stimulation drugs, what the type of gonadotropins and what are the oral ovulogens which are recommended by the guideline. The first one is the gonadotropins which can be urinary recombinant. Second is the stimulation drugs which can be letrozole and clomiphene citrate. Coming on to gonadotropins, when recombinant human FSH is compared to HMG, both are equally recommended, recombinant human FSH and HMG, because considering the tropical conditions of some countries, the HMG needs more storage facilities. So it is needed that the cold storage should be maintained. So provided the cold storage is properly maintained, the recombinant human FSH as well as HMG both are equally efficacious. Recombinant human FSH versus the purified FSH. So they both are equally recommended in the GnRH agonist protocol. When recombinant human FSH is compared to highly purified FSH, then again they both are equally recommended. Recombinant human FSH versus recombinant human FSH plus recombinant human LH, which also comes by the name of pergoveris. So when we are comparing these both, what the guidelines say are, they are equally recommended in the woman who belongs to general IVF population or even low responders, or in the woman with advanced stage. So the pergoveris has no added advantage over the recombinant human FSH alone. Comparing the recombinant human FSH versus FSH plus HMG. So both are together not recommended over FSH or HMG alone in normal as well as in low responders. Long acting versus daily recombinant human FSH. Long acting, what we call as corifoliatropin. So both are equally recommended in GnRH antagonist cycles for normal responders. Folitropin delta. So folitropin delta and folitropin alpha, beta, so all are equally recommended for ovarian stimulation and no one is more efficacious over the other. Second part is combination of gonadotropins with other stimulation drugs. First is the letrozole. So in the patients who are high responders, it is not recommended. In the patients who are normal responders as well as low responders, letrozole has no added advantage. So it is not recommended. When clomiphene citrate is combined with gonadotropins, for high responders it is not recommended. Even for normal responders it is not recommended. But for low responders, clomiphene citrate alone or in combination with gonadotropins and gonadotropins alone are equally recommended for predicted low responders. Next part of the guideline is adjustment of the gonadotropin dose, which is not recommended. Any type of adjustment mid stimulation phase, either increase or decrease, is not recommended. Coming on to the adjunct therapies, there are many adjunct therapies: metformin, growth hormone, testosterone, dihydroepiandrosterone, aspirin, indomethacin, sildenafil, and antioxidants like myoinositol. So there are some guidelines which say they are recommended and some says they are not recommended. So let's see what Eshre has to say in their 2025 guideline. Firstly, the metformin. Metformin is not recommended when the GnRH antagonist protocol is used in the woman with PCOS. It can have some role if the GnRH agonist protocol is used. But guidelines do not promote GnRH agonist protocol in PCOS patients. They only promote GnRH antagonist protocol in PCOS patients. Role of growth hormone in patients with normal, low responders or PCOS. All of these category of patients, growth hormone is not recommended. Again, for testosterone, same thing. Some studies were there which were showing the role of testosterone, dihydroepiandrosterone role in patients with low responders, but guidelines do not suggest use of these. They do not recommend use of these testosterone, dihydroepiandrosterone just to increase the efficacy of the cycle. They do not recommend it. The adjunct therapy dihydroepiandrosterone, that is also not recommended for low responders as well as in normal responders. Aspirin is thought to increase the perifollicular blood flow, but despite that, theoretically it is improving the perifollicular blood flow, but in the stimulation phase it is not shown to improve the outcome. The number of oocytes retrieved are similar when the aspirin is either used or not used. So that's why it is not recommended in general population or for the low responders. Sildenafil, it improves the blood flow, and so that is one of the reasons it was thought to increase the stimulation outcomes. But across the studies, use of sildenafil before or during ovarian stimulation has not shown any benefit, so that's why it is not recommended for low responders. Antioxidants have also not shown to give any added advantage, just increasing to the cost of the treatment, so they are not recommended to high, normal or low responders groups. Non-conventional start of ovarian stimulation, which we also call as random start ovarian stimulation protocols. They can be used when a fresh transfer is not intended. Risk of OHSS in case of concurrent spontaneous conception should always be discussed with the patient. The double stimulation. There is a change in the recent guidelines. The double stimulation can be considered in the urgent fertility preservation cycles, and the present guidelines, it allows the double stimulation when the intention is to accumulate the oocyte or the embryos when the fresh transfer is not planned. Coming on to part D of the Eshre controlled ovarian hyperstimulation guidelines, which is regarding the fertility preservation and oocyte donation. First part is the ovarian stimulation for fertility preservation. The initiation of stimulation for fertility preservation for the patients who are facing the gonadotoxic treatment, the ovarian stimulation for fertility preservation can be started irrespective of the menstrual cycle phase, which we call as random start protocols. Ovarian stimulation for fertility preservation. In ovarian stimulation for fertility preservation in estrogen sensitive diseases like breast cancer, the concomitant use of anti-estrogen like letrozole, tamoxifen, that can be considered. What are the pituitary suppression protocols which are being used? The GnRH antagonist or progesterone protocol. They are recommended over the GnRH agonist protocols for pituitary suppression in elective oocyte cryopreservation. So either of both can be used. Final oocyte maturation protocol, GnRH agonist is preferred because it is more safe rather than the HCG. Coming on to ovarian stimulation for oocyte donation. Initiation of stimulation, conventional follicular start or random start ovarian stimulation are equally recommended because we are not intending for transfer. So that's why anytime we can start the stimulation. Important point is, for the donor, the natural pregnancy can always happen. So she must adopt a contraceptive measure. Which contraceptive can be used is any type of contraception, whether it is hormonal, non-hormonal, oral, vaginal, or intrauterine. Either of these can be used even while she is undergoing the stimulation process for oocyte donation. The pituitary suppression for oocyte donation, GnRH antagonist and progesterone protocol are equally recommended. GnRH agonist protocol is not recommended because of the less safety associated with the GnRH agonist protocols, because we do not want any OHSs in the donor patients. Ovarian stimulation, with what drugs we should do? Recombinant human FSH, purified FSH, long acting or HMG, all are equally recommended, and they should be individualized. The dose should be individualized based on the ovarian reserves of the donor. Final oocyte maturation, it should be with the GnRH agonist protocol, not with the HCG, because to prevent the risk of OHSS in the oocyte donors. So thank you friends. This was about the part 2 of the controlled ovarian hyperstimulation guidelines released by Eshre 2025. In our next video, we will come up with the part 3 of the guideline. Thank you.